Good afternoon, everyone. Today we are going to have a discussion on practical points in pediatric refraction. So we have divided the topic into five subtopics, and we'll move on to each refraction. First, we'll be dealing with the basics of pediatric refraction. Refractive errors are the leading cause of visual impairment in children. Early detection and management is very crucial for the optimal visual acuity, binocularity, and overall development of the child. Any delayed or inappropriate correction can lead to irreversible amblyopia, as well as it can impair the child's optical as well as neural development. So we all face unique challenges in pediatric refraction. So it's very difficult to attain a correct value. So we'll get a limited cooperation from the studied subjects. They lack the attention span. The values that we get will be of low reliability and they will be inconsistent. They have a greater accommodative range which masks the true refractive status of each kid. And it is always difficult to quantify the visual status, as we shouldn't forget the risk of amblyopia as well. So the visual assessment of any child should be age appropriate. For infants, we can follow the CSM technique, that is central fixation and steady fixation and maintenance. We can look for the movement assessment. Preferential looking charts can be taken into consideration. Any objection to occlusion testing can be taken, and fixation preference can also be evaluated. But in case of preschool children, you can look for you can take help with the Allen's picture chart, HOTV matching letters, Lee symbol charts, or alphabet recognition cards. In school-going children, we can have the adults techniques like Snellen's chart, Logmar's chart, etc. So it should also consider a comprehensive eye examination protocol, including Hirschberg test, cover-uncover test, extraocular motility cases in all cases, convergent testing, a complete strabismus evaluation, anterior segment, dilated fundus examination, as well as retinoscopy. So what are the indications of a cycloplegic refraction in a kid? Every non-verbal child, every symptomatic patient, that is symptoms of asthenopia are there. All young children, any cases with strabismus, all children who are suspected to have pseudomyopia or poor correlation of subjective refraction and their symptoms, all have to undergo a cycloplegic refraction. So these are the different cycloplegic agents that we commonly use. 1% cyclopentolate, which is a gold standard for routine pediatric practice. It has a rapid onset of action with adequate cycloplegia and fewer systemic side effects. 0.5% cyclopentolate is preferred in younger children, infants with minimal systemic absorption. Atropine 1% is usually reserved for specific cases where you are expecting a child with a severe esotropia where you want maximum cycloplegic effects and all. So these are the various comparison table of various cycloplegic agents available. As we know that atropine sulfate, the peak effect comes at 3 days. So the retinoscopy has to be done on the 4th day and PMT has to be done after 2 weeks. And it has a Stoner's allowance of +1. Hometropine and cyclopentolate, the peak effect comes up at 90 minutes. So retinoscopy has to be done at 90 minutes and PMT has to be done after 3 days with the Stoner's allowance as noted in the table. Tropicamide and phenylephrine are agents just used for mydriasis. It is having a very negligible cycloplegic action. So this CTC regimen is the most commonly used regimen nowadays in the OPD setup. So for CTC regimen, first you apply cyclopentolate 1% eye drop in both eyes. 5 minutes later, you put the second drop of cyclopentolate eye drop, and 5 minutes later, again one drop of tropicamide and phenylephrine combination, and you perform retinoscopy 45 minutes after the first drop has been instilled. So it gives comparable cycloplegia to 1% atropine and very easily followed regimen in the routine OPD practice. So when you compare the systemic side effects of these cycloplegic agents, atropine is having the most severe systemic side effects, including hypothermia, restlessness, irritability, tachycardia, flushed skin and all. Cyclopentolate, even though it is not having that much of a severe systemic side effects just like atropine, you should take into account the possibility of drowsiness, ataxia, disorientation, incoherent speech, all these things. So should be used in caution with children with neurological disorders. So this is a clinical guidelines for prescribing a spectacle according to American Association of Pediatric Ophthalmology and Strabismus. When we look into this table, we can know that myopia has to be prescribed only if it is more than -4 diopters in infants and up to 1 to 2 years, and you should consider prescribing myopia if it is more than 3 diopters in 2 to 3 years of age. Hyperopia without esotropia has a little leverage. You can wait till +6 diopters, but if it is with esotropia, it has to be corrected even if the value is +2 diopters in an infant. Astigmatism also has certain values followed by like 3, more than 3, more than or equal to 2.5, and more than or equal to 2 in the respective age groups. So this is a national consensus guidelines for correction. So it follows a similar trend, but the values are slightly on the lower side in our country. That is, myopia has to be corrected if it is more than -3. Hyperopia, in the previous year it was 6. In national consensus it is +4. And if it is having squint, that is esotropia, it has to be corrected even if the value is +1.5 diopters. So gold standard of objective refraction is always retinoscopy. It helps us to determine the sphere, cylinder and axis in a precise manner, very effective in non-verbal children and with limited cooperation as well. So what are the key considerations that we should take into account before prescribing a child? You should take a note of the dynamic refractive status, because the refractive status keeps on changing with the age and the growth of the eyeball. And you should give a priority to hypermetropia, because hypermetropia has a more chance of amblyopia. And myopia, if it is a minimal myopia in a toddler, it need not be corrected. But if it is significantly affecting the vision of the toddler, it has to be corrected. Amblyopia risk has to be taken into account for all the cases, and you should also look for a presence of strabismus. If there is a presence of strabismus, the full cycloplegic correction has to be given. So in hypermetropia, as I told, early correction is prioritized because it has the risk of refractive accommodative esotropia and amblyopia. And infants less than 6 diopters without any squint needs no correction, and even in older children slightly under correction is acceptable without esotropia. But in case of esotropia, it has to be given a full cycloplegic correction, or in case of high AC by ratio also full cycloplegic correction has to be given. And you should also consider giving a executive bifocals to control both distant as well as near vision. Myopia management, on the other side, you should always avoid overcorrection. You prescribe the least possible minus power to the kid. But if there is any intermittent exotropia, even if the myopia is very small, it has to be corrected. So myopia less than 4 diopters in infant does not require any correction usually. In preschool children, you prescribe the lower degrees for myopia to match their visual demands. And in school age, it has to be corrected to optimize the distant vision as well as the classroom learning. Astigmatism cannot be overcome by accommodation, so it also has this amblyogenic threshold. So cylindrical power more than 1.5 to 2 diopters has to be prescribed. And another thing is, pediatric population adapts well to or adapts easily to the cylindrical powers, even if it is a high cylinder, on contrary to the adult. So it can be considered prescribing early enough. And you should also consider the fitting thing in the spectacles regarding the astigmatic cylindrical axis. Anisometropia is again a high risk area. Anisometropic and hypermetropic anisometropia and cylindrical anisometropia produces more amblyopia. So a difference more than 1.5 diopters in case of hyperopia and astigmatism needs correction. In myopia, you can be till 3 diopters. If there is amblyopia, you should treat the amblyopia as well. In case of aphakia and pseudophakia, initial postoperative period, you should overcorrect by 2 to 3 diopters, and by first year, you reduce the overcorrection by 1.1 to 1.5 diopters, and long termly, you should convert into a bifocal lenses, so that there is vision at both all distance and intermediate areas. Thank you.